Good evening and warm welcome to the fourth session of our Pediatric Orthopedic Fellows training program. So initially we will have few basic questions about that, and after that we will go to the main important part of the discussion. So this session is basically on the clinical examinations of a child with cerebral palsy. And as discussed last time, clinical examination is very important source of information. But the most important thing in cerebral palsy is that before we use this information in the decision making, we really have to use a filter. What is or how much is important and how much we have to correlate with other things that we are going to discuss in today's session. I'm sure that you will have a lot of questions. And if you have questions at the end of the session or after the session, please write to me. What I can do is, like, if I will be able to answer those questions, I will answer those questions directly. Or if that's not possible, I will take the help of Dr. Benjamin Joseph or Dr. Freeman Miller to answer your question. Albert Einstein rightly said that you don't have to know all the answers, because you just need to know where to find out the correct answer. So let me say that I know the source. We have Benjamin Joseph and Freeman Miller with us who can give us the correct answer when the need arises. So before we ask the fellows to present about how to examine certain muscles, I would like to ask a very simple question to Benjamin Joseph, that how does clinical examination is different for a GMFCS 1-3, level 1-3, which we call it ambulators, and GMFCS 4 and 5, because the aim of treatment is very different in both the groups. So similarly, clinical examination also has to be very different. So with a very simple question, I request Benjamin to share his views.
Yeah, clearly, as you said, the aims of treatment are completely different in these two groups. GMFCS 1-3, you're trying to see how you can improve the pattern of gait, and you're focusing on the abnormalities of posture and gait that you see. And one of the integral parts of that examination involves examining the child standing and walking. So that part of the examination doesn't really have any relevance in GMFCS 4 and 5 because they don't walk. At least they don't walk much. The focus of examination of GMFCS 4 and 5 is much more on looking at the complications of the condition rather than abnormalities in gait. And we're going to look much more onto the problems of the hip. Distally, as far as the knee and the feet are concerned, you're just going to look to see whether there are deformities which preclude comfortable sitting. Apart from that, I don't spend too much time, if there is a valgus of the ankle in a child who doesn't stand and walk, it's immaterial. But if there's a severe equinus which precludes, sitting comfortably or resting the foot on the ground, I may do something for that. I may want to know if the hips can be abducted sufficiently to prevent problems. So I'm going to focus much more on the hips than elsewhere. So yeah, so the area that I'm going to examine, the posture in which I'm going to examine will vary, and the emphasis will vary, undoubtedly.
Yes, so that's a very important thing. The next question, which is very important for again, and I don't have a very clear answer to that, and that's why I want to know from you, that we carry out clinical examination in a lying down position.
Yeah.
And from that, we try to gather the information. Now, the GMFCS level 1-3, they have a major issue of abnormal gait. And our aim is to improve the walking. So how much relevant the information or how much reliable the information which we are getting from the lying down position for a problem which is of a standing and a walking posture, where tone will be very different in both the situations.
No doubt there's difference in tone with standing and lying. But there, you don't have much of a choice because you can't do many of the tests with the child standing up. But the important thing that I would emphasize is you make the child walk first. Look at the abnormalities that you notice, and then have the patient supine looking for the possible causes of A, B, and C. For example, if the child is walking with hip inflection, what could the reason be? Is it primarily at the hip, or is it a secondary to a knee problem? And that you can sort of get some clues while you see the child walking and confirm it with the child recumbent. So I agree, there is a disconnect between what you want to see with an ambulant child and you're examining with the child recumbent, but then you've got no choice. And I think the sequence should be to see the child walking so you know what abnormalities you have, and then get the child recumbent and test to see whether you can work out what was structures abnormal leading to the abnormality in gait that you've noted.
Okay, that's very important. And like exactly what you said, I also try to look at it that way. But the major challenge which I face is like how or what is happening in my mind, particularly when I am looking at the child gait and when I am examining the child. Some process, some thinking goes inside our mind, and how to pass on that thinking to the young pediatric orthopedic surgeon is a challenge. But Freeman is with us, and let us have his opinion about this important question. Freeman, the question is like, how do you or how much importance you give to the clinical examination for a problem of walking, which is completely in a different posture, and tone is also very different in that posture?
I think for me, observing how the child is walking is half of the problem, and to understand what the gait pattern is like, you have to have a good physical examination to understand what might be the etiology or the cause of that deformity. So as an example, a child who is walking with internal rotation of his hips, you've got to have a good examination of the femoral rotation, muscle tone, know the child's age. All of those things have to go in. I think the physical examination is a poor indicator to predict gait. But on the other hand, you cannot evaluate the problems of gait without a good physical exam.
And do you examine the child on an examination table first, and then you look at the gait, or what Benjamin said, that you look at the child first, walking, or observe the gait first, and then you come to a physical examination? Which one is first?
I think in general, I do the physical examination first, but I'm not sure it's that important. Sometimes I do the physical examination first, watch the child walk, and then go back and examine specific areas again where it seems to be discordant.
Okay, thank you. So let's move on to the next point, which is very important. And that is a very important point to differentiate between the spasticity and contracture. So before we understand any clinical examination, we always have to understand that in cerebral palsy, there is a tone, increased tone, or a spasticity which is playing a role. And whatever length we assess on clinical examination, there are two components. One is a contracture and second is a spasticity. So whatever we are going to discuss in next 5 minutes is applicable to all the tests which we are going to carry out. So I will tell you something about the modified Tardieu test. For that, first of all, let us understand the normal range of motion. And for the sake of understanding, I am giving example of ankle. But whatever we discuss for the ankle can be applied to the knee, is also applicable to the hip joint. So let's take, we are looking from the side, and this is the right side. The ankle is in full plantar flexion. This is a normal person. And when we try to dorsiflex the ankle, we get a dorsiflexion up to 20 degrees. So we have a range from 30 degree plantar flexion to 20-degree dorsiflexion. So it's an arc of 50-degree, which is there. Now, whether we carry out this slowly or rapidly, it's going to be same in a normal person. So in a normal person, the arc is same. So even if we carry out a rapid stretch, the arc is 50-degree. On the other hand, if we carry out a slow stretch, again, the arc of movement at ankle is going to remain the same. That's at 50-degree. Now let's take a spastic child, and for the example, the calf muscle is spastic. So this spastic child is going to behave differently than that of the normal child, and how that is different, that we will see. We know that spasticity is a velocity dependent stretch reflex. In a simple word, when we stretch rapidly, we get a catch, and when we stretch slowly, we don't get catch. That's what we understand by velocity dependent stretch reflex. So again, on slow stretch, there is no catch, and on the fast stretch, we get a catch. So, and if we apply faster, then there is an early catch. So let us see that with the animation. So this is where we applied a rapid stretch. So there is a range of motion from 30-degree plantar flexion to 0-degree of plantar flexion. Now, if you apply a slow stretch, there is a full dorsiflexion available. So from 0-degree or a neutral position, a further 20-degree dorsiflexion is possible. If we draw this with a picture, the blue demonstrates the normal arc. R1 is the first catch we got. And after that, we apply a sustained or a slow stretch. And what we get further, that is called R2. And the range between that is shown in a pink. So blue one is a functional range which is available to a child, while the arc between R1 and R2 is the spasticity range. The same child, usually in the natural history, after few months or few years, over a period of time, there is a further appearance of a contracture. So now there is a functional range, then there is a spasticity, and there is a contracture. So let's see how that plays a role. So we applied a rapid stretch. We got a first catch at the 10-degree of plantar flexion. Then we applied a sustained stretch. And from 10-degree of plantar flexion, we got a further dorsiflexion up to 10-degree. And after that, further dorsiflexion is not possible. So now if we see the blue one, that is up to R1, is the functional range. Then the pink one, which is an arc between R1 and R2, is the spasticity. And what is shown as TR, that's a terminal range. And a gap between R2, which is shown in a black, is actually the contracture. So previously there was only R1 and R2, means there was a functional range and a spasticity. Now there is addition of contracture. Let's see, after a few more months or few years, the situation is slightly more advanced. And here, with a rapid stretch, we get a dorsiflexion up to 10-degree of plantar flexion. So there is a 20-degree of functional arc. Beyond that, you applied a slow stretch or a sustained stretch, but this time the dorsiflexion is only possible up to neutral position. That's a 0-degree plantar flexion. And beyond that, the further dorsiflexion is not possible. If we show this, then the blue one is a spastic. The blue one is a normal functional range. The pink one has reduced, and the black one, which suggests contracture, is increased. Now the question why we really need to understand this. The reason is the neuromuscular blockage, they work only on the pink and they don't work on the black part, that's a contracture. So whenever we look at a child, we need to differentiate which one is more responsible, whether it's a spasticity or a contracture, what is responsible, that we need to know. And once we know that, then we can decide which treatment is best for a child. So with that, I think it's a time for the fellows to present their views. So I invite Devendra and Siddharth to present their views about the spasticity management. And once they say, then if I need to add something, I will show you some pictures which are useful to you to understand this. So with that, I stop sharing and I request Siddharth and Devendra to take over. Before they start their presentation, Freeman, would you like to add something on what I described?
I think it's a good description. Something that at some point we might discuss again is also separating out dystonia from spasticity from contracture. But I think I agree completely. I have nothing else. I think it's a very good description.
Okay, Devendra, please.
Sir, screen sharing is disabled, sir. Can you please?
Yeah, just let me check again. Yeah, now I allowed you, please.
I hope you can see my presentation, sir.
Yes, please.
Sir, today I'll be describing the examination of hip flexors and adductors in cerebral palsy, sir. So, good evening to all. And so I will start by describing fixed flexion deformity of the hip. Fixed flexion deformity of the hip is seen in spastic diplegia or quadriplegia. It can be fixed flexion deformity can be elicited by the Thomas test and Staley's test. So the Thomas test is performed by flexing one hip to the knee chest position and flattening the lumbar spine and leveling the pelvis while allowing gravity to extend the hip that is being examined. Any residual flexion represents the hip flexion contracture. So in this diagram, to the bottom right, it is around 60 degrees. So you can see this diagram on the top right. This demonstrates the test. So if there is a bilateral involvement, we can do the Staley's test. In this, the prone and the patient is kept prone. Hip extension is performed in the prone position with the lower extremity flexed over the end of the table, flattening the lumbar spine and leveling the pelvis. One of the hip remains flexed at 90 degrees, while the clinician simultaneously extends the other hip while palpating the pelvis, as demonstrated in this diagram, sir. As soon as the pelvic motion is detected, the amount of the hip extension is stopped, and as the amount of residual hip flexion is the flexion contracture of the hips. Now, coming to the hip adductor contracture, patients with adductor spasticity have a narrow base of gait with resultant scissoring. Adductor contracture with concomitant flexion contracture predisposed to hip dislocation. And it is important to differentiate true adduction from pseudo-adduction deformities. In pseudo-adduction, there is increased femoral anterior version with crouch at the knee, resulting from the resulting in the appearance of scissoring, sir. But there will be we can make out the difference by seeing at the internal rotation of the femur, so that we can make out by observing the patella. So coming to test for rectus, sir, that is done by the Dunkel-Ellis test. the patient is positioned prone with the hips kept in extension. The knee joint is passively flexed on the side of examination, and normally there should be no motion at the hip joint, and no hip or pelvis should not rise. But if there is a rectus femoris contracture, passive knee flexion causes that side of the pelvis to rise. And the disadvantage of this test is that it's not specific for rectus femoris in patients and with hip flexion contracture secondary to iliopsoas tightness. So, and coming for the adductors, sir. So, to differentiate between adductors and hamstring contractures, we can do the Phelps test. It is a test for gracilis, which is a biarticular hip adductor. Combined hip abduction angle, which is the angle between two thighs, is measured in with the knee in extension, sir. And after flexing the knee, again the maximum hip abduction of both sides is measured. So if there is an increase in we are able to do more abduction with the knees flexed, it indicates that the gracilis is tight, sir. So coming to measurement of the popliteal angle and the hamstring shift, sir. The popliteal angle measurement is used for assessment of hamstring tightness. Here, the child
Devendra,
is,
we stop this because we have already given this to Jai Prakash, so he will be presenting this. So please skip this portion of the popliteal angle part.
Okay, sir, sure. Sir.
Okay, now the one question to you before we go to the more question. In one of the picture you shown the child abduction was examined in a prone position. So in your clinic, you carry out in a prone position or you look at the abductor's length in a supine position?
Sir, we do it in supine, sir. We can put both the lower links at the side of the table and do the same thing, sir. Supine or prone, we get the same results, sir. Actually, we are supposed to get the same results.
Good. And the next question, which I'm going to ask both Benjamin and Freeman about, there was one test in which one picture in which they showed that hip was flexed to 90 degree and then the abduction was carried out. What is the importance of that test? Yeah, Freeman, what is your take on that?
Yeah, I think that test's a main utility for me is for patients like who are quadriplegic, GMFCS 4s and 5s in their sitting posture. So if you are concerned about the inability to abduct one side for sitting, to get them into a comfortable sitting position, that's its main use. It's not really useful in evaluating the hip for walking because you never flex the hip 90 degrees in walking.
Yeah, Benjamin, would you like to add anything on that?
No, nothing more to add on that.
Okay, fine. So what we do is like what we discussed till now. I have asked few or like prepared few case scenario, and we will be asking fellows to say something on that. What is their interpretation based on that? So let's have that. So this will be a bit repetitions, but still I think that it's very important to understand that because some of the pictures which Devendra showed, there was a wrong message going. So let's understand that in a better way. And this session is even for the postgraduate students. So for them, this will be more useful because Thomas test is a very common test which is asked in exam. So short hip flexors leads to flexion at the hip joint. So let's say that this is a normal child where the psoas or the iliopsoas is normal in length, and this child will be able to lie supine on an examination table with hip completely extended. However, like this, when the iliopsoas is short, when child tries to lie down on the examination table, and if spine is touching the examination table, then femur will be remaining in slight flexion position, like shown in this picture. If we try to bring it to the table, make it parallel to the table, then that will lead to increased lumbar lordosis. So either the spine touches the examination table and the femur remains up, or if we make femur parallel to the floor or parallel to the examination table, then there will be increased lordosis. When the same child gets up and is in a standing posture, you can see that the hip or the pelvis is tilted anteriorly, it's forward tilted, and that results into increased lordosis. And when you look at this child, their abdomen is protruding. So these are the signs which tells us about that probably there is a problem at the hip flexors. How do we examine the hip flexion deformity? The most important point which I want you to understand is about how much contralateral hip should be flexed. That is a very important question. The one is, as per the description for the Thomas test, we are looking from the right side. So yellow is a side which we are examining, and the left side, which is shown in a pink color, is on the opposite side. So the first question is, how much opposite hip should be flexed till the lordosis is obliterated? It's not that 90 degree or 60 degree, but till the lordosis is obliterated. That's the correct answer. At that point, if you look at a blue line at the pelvis, which is joining the anterior superior iliac spine to the PSIS, that's a vertical line perpendicular to the examination table. And the yellow femur angle it forms with the examination table is the angle of fixed flexion deformity. Now, the important point is, if contralateral hip is fully flexed, as described by Devendra, that it should be the knee touching the chest, what will be the result? Let's take that we have overflexed the contralateral hip. Now we can see that the lordosis is obliterated, or there is a slightly reverse posture of the lumbar spine. If you look at the pelvis, now the line joining the ASIS to PSIS is not perpendicular, but it is backward tilting. And now if you look at the flexion deformity, that is the yellow femur making with the examination table, this is the angle. And this is how we say that this much is the flexion deformity. If you compare the previous figure where the pelvis was perpendicular to the examination table, this was the flexion deformity. So if we overflex the contralateral hip, we get the wrong idea about the flexion deformity at the hip. So the most important message I want to give, overflexion of the contralateral hip leads to wrong assessment or overestimation of the hip fixed flexion deformity. Benjamin, would you like to add something on this basic Thomas test and about the position of the contralateral hip?
Sorry, I agree with that entirely, because you can give an erroneous impression of an exaggerated deformity if you overflex the hip, the normal hip. So I think you need to be quite sure that you're not going beyond the normal limit of flexion the hip has, and then you can flex it more. I always use the hand under the lumbar spine to make sure that the lumbar lordus is obliterated. That we were taught in undergraduate days, and I still continue to do that because that's a good way to know whether the lumbar spine is touching the couch.
Yes, thank you. So we move on to the test for the abductors. Again, Devendra described it really well. So now let's take one practical scenario. So scenario one, I'm giving you the information about the right hip. Let's assume that the normal hip abduction is 45 degree. With the knee extended position, the examiner was able to carry out 20 degree of abduction. Then he bent or he flexed the knee joint, released the medial hamstrings, and after that he was able to abduct up to 35 degree of abduction. So there is a 15 degree increase in the abduction with the knee flexion. So now, what are your comments? So I want the fellows to comment about this. What do you understand by this test or by this clinical examination?
Gracilis is involved, sir.
Okay, gracilis is involved. Good. What else?
Both the adductors and gracilis are involved.
Very good. So both adductors and gracilis are involved. Why do you say like that? You are right, but can you explain the reason for that?
Because the normal hip abduction is mentioned as 45 degrees, so it's only 35 degrees. So
okay, right. So yes, so the 15 degree is by gracilis. So the correct answer is both gracilis and adductors are short. From 20 to 35 increase is by the gracilis. So the 15 degree component is by gracilis. And what is remaining from 35 to 45 is by the adductors. Okay, very good. So let's come to us examination finding of the opposite hip, the left hip. With knee extended, the examiner was able to abduct till 30 degree. And with knee flexion, 45 degree abduction is possible. So now, what are your comments?
probably gracilis is contributing to the 15 degree contraction.
Perfect. So only gracilis is contributing. Very good. Because with the knee flexion, the normal abduction is possible. Very good. Okay, we already questioned. So now we first of all understand about the popliteal angle. Before I ask Dr. Khatri, I would like to ask a very basic question. Again, I don't have an answer, and when I don't have an answer, there are two people to whom I always ask that question. So I will be asking that question to them. Before that, let us understand that when we talk of hamstrings, we have medial hamstrings.
May I interrupt?
Yeah, please.
Regarding the gracilis and the adductors, I have not actually come across a situation where gracilis alone is contracted and the adductors are not. I've not seen a clinical scenario. And also, I was taught that when you do an adductor release, always release the gracilis. So I do that. I'm not sure whether I'm right or wrong, but when I release the adductors, I always release the gracilis. That being the case, I don't make a distinction of trying to detect whether the gracilis is contracted more or less. If there's an adduction contracture, I do a release of the gracilis as well. I'd like to hear what Freeman says. Am I overdoing it or?
Yeah, I completely agree with that comment. And I think rather than ascribing the difference just to the gracilis, it would be better to ascribe it to the medial hamstrings, because I think the both semitendinosus and membranosus also restrict abduction, especially when you get out to the 35 degrees level of abduction, because then the moment arms of the tendinosis and membranosus favor them limiting for their abduction as well if they're contracted. And I also do the same thing. If I'm releasing the adductors, the two muscles I always release completely is the gracilis and the adductor longus. The gracilis has the longest adduction moment arm because it's most medial.
Okay, first of all, let me give my explanation. What you said, I fully agree, and I do the same thing in the practice. The case scenario which I described is only to make the fellows think that how much component is from which muscle. Otherwise, like when it comes to practice, my practice is also same for all the children to whom I am operating for the adductor release. I combine both adductor longus and gracilis. So,
Thank you.
yeah.
Thank you.
So basically, that's not like I'm trying to say that we be selective in the operative procedure, but that was basically to think about how to interpret clinically. Interpretation, exactly.
Exactly. Thank you.
Thank you. So when we talk of medial hamstrings, there are three: semi-membranosus, semi-tendinosus, and gracilis. So when I said gracilis in the previous example, yes, what Freeman said is absolutely right. It's all the three medial hamstrings, they are playing role in that. Gracilis being the medial most is the most important one. When we talk of a lateral hamstrings, there are biceps femoris, which is biarticular component, and a short head, which is a uni-articular or crossing only the one joint. So what are the effects of short hamstrings? That I'm trying to explain first. After that, we will try to look at the test. So the first effect, which is the first effect which we see in the clinical setting, is short hamstrings leads to reduced step length. And let us see that by this animation. So to understand these animations, we are looking from the right side, and we are going to focus on the right lower limb, which is in the swing phase. So right lower limb, we are going to understand. So this is half of the swing phase is over, and we are in the terminal swing phase. And this is how the knee extends. Now, if you look at this particular position, which is just before the next gait cycle starts, or the heel contact takes place, or the initial contact takes place, hip is flexed and the knee is extended. And this is a position where hamstrings has to be of maximal length, because hamstring is behind the hip joint and behind the knee joint, and this is where the maximum length of the hamstring is required. Now, if I ask you, like, suppose there is a slightest amount of hamstring shortening, what will be the effect on the knee extension at this particular part of the swing phase? Yeah, I want fellows to answer that question.
Reduce knee extension.
Very good. Reduce knee extension. Very good. So let's see that in the next animation. So now, as shown over here, the hamstrings are short, and let's see what happens when the knee tries to extend. It cannot extend fully because it is hip is flexed, so already hamstring is stretched at one end. Now if you try to compare with that the previous animation, this is the difference. And if you look at the heel length or the heel positioning, you can see that the first sign of the short hamstring is reduced step length. Sometimes it leads to apparent equinus. Many a times the person who is not well versed with cerebral palsy, gait abnormality, they look at the child and they said, oh, there is an equinus and let's operate on the calf. And the problem is not at the calf, but it is at the knee joint. And that is called a pseudo-equinus or apparent equinus. So let us understand why it looks like that. Again, we are looking at the right side in the swing phase, and this is how the limb is moving forward. We saw that if hamstring is short, the knee will not extend fully. So compared to the previous animation, now hamstring is further short, reduce in length, and it further restricts the knee extension. So in that case, the situation will be like this. This is a normal animation. Now we are looking at when the hamstrings are short. Now you can see that because of the short hamstrings, the further knee extension is not possible. And now if you look at the ankle joint, it looks that ankle is in equinus. But if you look at carefully, look at the ankle joint, it is at right angle, it's in a neutral position, but still it gives impression that there is equinus deformity. So this is called apparent equinus, and it is also because of the short hamstrings. The third sign which we see many a times very commonly, and parents also tells us about that when child sits with the knee extended like this, the spine is bent, and if you look at the reason, or if you try to understand the reason, the hamstrings are short, and because it is stretched at one end with the knee extension, it takes the ischial tuberosity slightly backward, and because of that the pelvis is tilted backward, and that leads to reversal of the lumbar lordosis. So this is very common during the examination. But as soon as you ask the child to sit with the knee flexion like this, with knee flexion, the hamstrings are relaxed at the knee joint. And because of that, now the pelvis, which was backward tilted, become normal. And that leads to a normal curvature of the spine. So this was with knee extension, and this is with knee flexion. So this is another test which we can see before we look at the popliteal angle. And the last one, with more further knee contracture, the child also stands with keeping the knee flexed all the time. So these are the various signs which we see before we look at the popliteal angle, or before we measure the hamstring length by a popliteal angle. Now, how can we assess the hamstring length? It's a biarticular muscle. And for that, we have a two tests. The straight leg raising test, which we very commonly do in a spine examination, and the test which is very common in cerebral palsy assessment is a popliteal angle. So my question to both our experts, that ultimately the message which we are trying to get is same. In the straight leg raising, we keep the knee extended and we try to flex the hip joint. While in the popliteal angle, we are trying to flex the hip joint to 90 degrees so that hamstrings are stretched at that point, and then we are extending the knee. So why there are two different tests? And the second, why SLR is not used to assess the hamstring length? Yeah, Benjamin, what is your answer to this query? You need to unmute yourself.
No, I kept it silent purposely because I didn't want to answer the question. No, I must honestly say I've never really thought very deeply about why we don't do the straight leg raising rather than doing the popliteal angle. Because I think if you do the popliteal angle, you can distinguish more than just the popliteal tightness. Yeah.
Okay. Yeah, Freeman, what is your understanding about this simple question?
Yeah, I think the straight leg raising test, from my perspective, has really two functions. One is it's looking for sciatic nerve pain, sciatic nerve irritation. So it brings out not there. You're not concerned only about the pelvis, the effect of the hamstrings, but the effect on the sciatic nerve. So you want to stretch it and tilt the pelvis as well at the same time. So for me, it's really the test. Probably, I don't know its history, but I've always thought it probably originated as a sciatic nerve stretch. It is used also for hamstring tightness. like for instance with spondylolisthesis. But my sense is in that situation, you're really looking for sort of normal to extremely abnormal. It's very little gradation. And because of the long lever arm that you have with the knee extended, it's very difficult to sort of have a gradated amount of extension to assess before the pelvis rotates. And by having the hip at 90 degrees and then observing the pelvis movement and very gently extending the knee, you get a much more sensitive evaluation of hamstring length. That's my feeling on the subject.
Thank you. So with that, we go to the next presentation by Dr. Khatri about popliteal angle assessment for the hamstring length. Yeah, Dr. Khatri.
Good evening, everyone. So I'll be talking about popliteal angle. Rab, in one of his papers, described pediatric orthopedic surgeons often consider hamstring lengthening when there is a persistent knee flexion of 20 to 30 degree in stance phase, and the popliteal angle is more than 45 degree, or when there is a hamstring overactivity on EMG. But the problem with EMG is that it does not give any information on etiology of the hamstring shortening. And the knee flexion during gait, which we consider for hamstring lengthening, it could be related to either hip flexion contracture or failure of the plantar flexion knee extension couple. And inadvertent hamstring lengthening, or the hamstring lengthening, when it is uncalled for, can lead to knee recurvatum in 6 to 40% of the patients. It can increase the anterior pelvic tilt and lumbar lordosis in up to 16% of patients. With this, he concluded that with modern techniques based on gait analysis, which allow assessment of the maximal musculotendinous unit length of individual muscle, one should be very particular about hamstring lengthening. So what is popliteal angle? It is the angle that the tibia subtends with the extended line of the femur. So in the popliteal angle, ipsilateral hip is flexed to 90 degree and knee is passively maximally extended. There are different figures available for normalcy. More than 55 degree of popliteal angle in an age group of more than 6 years, it signifies a significant hamstring tightness. So this is what unilateral or conventional popliteal angle is, which is measured with the typical lordosis, contralateral hip extended and ipsilateral hip flexed to 90 degree. The number recorded is in the degree, and which is missing from the full extension at the point of first resistance. So in this video, I am demonstrating how we measure the conventional popliteal angle. That is, the hip has been flexed to 90 degree with the other limb extended, and I give the gentle pressure for knee extension. And when I get the point of first resistance, I ask my assistant to put a goniometer, a universal wide large goniometer, transparent goniometer should be used for this particular test. So this is the popliteal angle, unilateral popliteal angle. The other one, the modification, is the bilateral popliteal angle, wherein the pelvic position is corrected and contralateral hip is flexed until the ASIS and PSIS, they come into this same vertical line. So hip flexion deformity shifts the ischial tuberosity proximally, and it can give false impression of hamstring shortening. So in bilateral popliteal angle, the opposite hip is flexed till ASIS and PSIS are perpendicular to the examination table, and hamstring surgery is indicated if the bilateral popliteal angle is more than 50 degrees. In this video, I am demonstrating the bilateral popliteal angle, wherein I support the other limb first and bend it beyond 90 degrees, and the examination side, I flex the hip up to 90 degrees, and then I do the same maneuver. And now I ask my assistant to measure the popliteal angle. So when the opposite limb is corrected, the opposite hip is flexed, then it gives some correction to the popliteal angle. The modified popliteal angle of more than 40 degrees is an indication that the medial hamstrings are short, and it indicates the need for further assessment. The further assessment can be done with instrumented gait analysis or computer model of the lower limb, such as SIMM. I do not have much of the details of SIMM available with me. This is a paper which gives good criticism of popliteal angle. It is one of the highly cited paper on popliteal angle, and it described that popliteal angle is inaccurate and unrepeatable test, and the variability of the test for conventional test was 74%, and with the modified test it was 70%. And the contributing factor, because in this particular study the subjects were examined on 2 different days, so the contributing factor could be different muscle tone of the subjects on 2 days of testing. And modified popliteal angle is potentially useful indicator of short hamstrings and the presence of limited muscle excursion if employed by a validated and experienced observer. It also concluded that conventional tests did not correlate with the maximum hamstring musculotendinous unit length during gait. Hence, it is not recommended in clinical practice. Surgical lengthening of the hamstring should not be undertaken on the basis of static clinical examination alone, and popliteal angle should not be used as an outcome measure after hamstring lengthening surgery. The other clinical use of popliteal angle could be, it has been used to determine the range of knee extension in neonates, which may be useful indicator of gestational age. For a normal newborn, it is 20 to 40 degrees, and full extension is achieved by the age of 11. And it is also a static indirect measurement of the hamstring length. So whatever I said, this table summarizes the popliteal angle, the whole procedure, and these are my resource material, including the article by Dhiren sir himself. Thank you.
Before we discuss more about the hamstring test or the popliteal angle, let me try to explain you with a few animations, and probably that will give you a better understanding of the thing. So let's have that understanding first, and after that we go to the discussion. So this was like where we stopped. So let's go further. So let us understand the rationale of bilateral popliteal angle. What he showed was very true, but the important thing is like why there is a second test which is called a bilateral popliteal angle test. So to understand that, when the contralateral, let's understand that when the contralateral hip flexors are short, contralateral means the side which is away from or the other than the one which we are examining, the hip flexors are short. In that case, when the contralateral hip is fully extended, what will happen? The pelvis will tilt anterior. When pelvis tilts anteriorly, the ischial tuberosity moves proximally. And when ischial tuberosity moves proximally, the hamstring's origin, which is from the ischial tuberosity, that also moves proximally. And that leads to an idea or the appearance that hamstrings are short. So let us understand that why this bilateral popliteal angle test become available. So this is where the opposite hip is not extended, but is flexed in such a way that pelvis is neutral, means a line joining the anterior superior iliac spine and the posterior iliac spine, PSIS, is perpendicular to the examination table. So opposite hip is not flexed as shown in that, but the most important thing is like we have to look at that now pelvis is in a neutral position. After that, we carry out a popliteal test like this, and whatever popliteal angle we get is called a bilateral popliteal angle. Usually that is less if I'm coming to that question, but so let's say that the previous popliteal test was this much and the bilateral popliteal angle is less. The difference between the two is called hamstring shift. Now, my question to fellows, that what does hamstring shift test suggest? Let's say that we have a 20-degree hamstring shift. What does it suggest?
So there is an anterior pelvic tilt is there, sir.
Yes, so the importance of that is very right, that hamstring shift reflects anterior hip structures length of the opposite hip, or the contracture of the hip flexors of the contralateral hip. That's what we understand by the hamstring shift. Very good. Already prone rectus test was described by the previous fellows, but let's understand by the prone rectus test. So rectus is stretched when hip is in extended position and the knee is in a flexion position. Because of its position, it's anterior to the hip joint and anterior to the knee joint. So this is where the patient is in a examination table, is in a prone position. Now the knee is extended. Now this knee is flexed to 90 degree, and in a normal position there will be no effect at the proximal end of the rectus and pelvis will remain like this. But let's take a situation where hamstring is short. So in an extended knee position, the pelvis remains perpendicular or in a neutral position. But as soon as we flex the knee joint, we are stretching the rectus at distal end, and the proximal end of rectus will pull the anterior part of the pelvis downwards. And now the pelvis will tilt anteriorly and it causes the flexion at the hip joint, which suggests the short rectus. So this is what the test is. This is from a YouTube. When the knee is flexed, the hip is elevated. On the other hand, this is a normal rectus, that even with the full knee flexion, there is no lifting of the hip joint. So the rectus is of normal length. Now I will like to ask two questions, but the first question is, how much knee should be flexed in the prone rectus test? Because I have asked this question based on the following three figures. This is what the starting position, with the knee almost extended, the hip is normal. When it is flexed to 90 degree, the hip is normal. But when the further flexion at the knee was carried out, now pelvis is, or the hip is flexed and the pelvis is lifted. So my question is, how much knee flexion is required for a prone rectus test? Yeah, Freeman.
Yeah, it's a good question. I think in adolescence, you will find both the hamstrings and the rectus during their rapid growth phase in completely normal children can be short, meaning they're tighter, but they don't have any impact on gait. So it is the other component that you also have to consider, that's spasticity. So with the prone rectus test, if you do it fast and there's a catch, say at 70 degrees, then that to me is quite significant. If on the other hand, the catch doesn't occur until 100 degrees, and then you can further flex, to 120, then that's plenty. It is that combination both of the absolute contracture, which the Eli test can show if you go slow, which you mentioned earlier, or where that catch occurs. And I think probably the catch is probably more significant because in swing phase of gait, it's pretty fast, and that probably initiates the end point.
Yes, that is a question. That was a second question I was going to ask. But my question is like up to how much knee flexion, whether we should test it to a 90 degree or it should be a full flexion.
I usually start and go from, I try to keep the opposite knee extended so that I can look at the individual knee. And I start at extension and then go as far as until I see the buttock rise. I use the buttock rise as the final endpoint and record that as the degrees of Eli test. And then the first catch as the sort of where the Eli test spasticity is positive. That's how I record, or how we record it in the lab.
Okay. Benjamin, how do you record this test findings?
I don't quantify it. I just say it's positive or negative. I tend to do a rapid flexion, and when it's spastic, the buttocks quickly rises up. You can see, when there's that catch. And what I do is I rest my hands on the buttocks and try to bring the pelvis down. And if it's pure spasticity, I can get it absolutely straight with the knee flex. But if there's a contracture, the buttocks remains elevated. So I don't quantify it. I make sure I try to separate rectus spasticity from a true contracture. And that can be fairly well done if you do a rapid test and you see the buttocks just jerking upwards, and then you gently push it down steadily. It comes flat and there's no, the pelvis is not lifted up. And then you know that there's no contraction. But if it stays up in spite of your gentle pressure, then you know that there's a contraction.
Okay, and then there was another point brought up by Freeman, which I forgot to put as a question. You do one by one or both the sides together as shown in this figure?
I tend to do both together because it's a little easier to do. I'm not sure whether that's wise, because I get the impression that usually it's symmetrical. So maybe I'm wrong.
Good. So now we come to another important muscle, and that is a gastrosoleus length. I now ask Akash to share his presentation about how to look at the gastrosoleus length. Over to you, Akash.
Yeah, so I'll be talking about the silver scale test to assess the gastrosoleus length. Yeah, so the test is named after Dr. Nils Silverskjold. So the interesting fact is he was an Olympic gold medalist in artistic gymnastics. He represented Sweden, and he did most of his work at Karolinska Institute, Sweden, under Dr. Hageland. So this was a part of his dissertation. Actually, he stated that the equinus is essentially inflexible. Equinus that is essentially inflexible with the knee fully extended, but capable of being corrected passively when the knee is flexed. Then the cause is a gastrocnemius cause, and what he did was he transplanted the gastrocnemius head from the distal femur to the proximal tibia. And for persistent equinus, whether the knee is extended or flexed, he said that the cause was both gastrocnemius and soleus, and for these patients he did tendo Achilles lengthening. So in the test originally described by Dr. Silver-Skjold, it was not more about measuring the ankle dorsiflexion. Rather, he quantified it by the force required to dorsiflex the ankle in knee flexed and knee extended positions. So this is the gastrosoleus complex. So you can see that the gastrocnemius, it actually passes across not two but three joints. It passes across the knee joint, the ankle joint, and the subtalar joint. This is important to remember. And the soleus, it originates in the posterior tibia and fibula and inserts onto the calcaneum through the Achilles tendon. So here, so I'm trying to show two situations. So this is the first situation in which gastrocnemius is contracted. So you see that the foot is in equinus when the knee is extended, and we apply a passive force to the foot, trying to dorsiflex the ankle after stabilizing the subtalar joint, which is very essential. If we do not stabilize the subtalar joint, we'll estimate the dorsiflexion, we'll overestimate the dorsiflexion. So as we flex, when only gastrocnemius is contracted, as we flex the knee, we can see that the effective length of the gastrocnemius decreases, and it allows us to dorsiflex the ankle. And compared to when both the gastrocnemius and soleus are contracted, you can again see, similar to the last setting, the foot is in, the ankle is in equinus in the knee extended position. But as there is a contribution from both gastrocnemius and soleus, you can see that even on applying passive force, even with the knee flex, we are unable to dorsiflex the ankle. So this is the basis of the Silver-Skjold test. So I'll again show it on a patient. So first I'm correcting the, I'm putting the subtalar joint in a neutral position, locking it. And then I'm trying to passively dorsiflex the ankle while I'm flexing the knee. So you can see in this patient, I am able to dorsiflex the ankle. And when I'm extending the knee back again, it's going into equinus. So there's possibly the deformity is due to a gastrocnemius cause in this patient. But a very important thing to remember is we have to stabilize the subtalar joint, because like any component of eversion, it comes with a dorsiflexion, and any inversion, it comes with a plantar flexion. So one more better way is to just put your thumb on the, I have not done it in this video, but put your thumb on the talonavicular joint, and when it's reduced, that time you try to assess the passive dorsiflexion of the ankle. So this is an article I saw. They compared the efficacy of a two-hand technique versus a single-hand technique in Silver-Skjold test, and the result was they were overestimating the dorsiflexion when they did it with a single hand. So this, when you do it like this, it requires another assistant. So he's stabilizing the midfoot and the hindfoot and then trying to assess the dorsiflexion. Whereas when you do it with one hand, you are actually, you tend to overestimate the ankle dorsiflexion. So interpretation, so we measure ankle dorsiflexion from the lateral aspect in knee flexion and extension. So if ankle is plantar flexed in both knee flexion and extension, the cause is mostly a gastrosoleus contracture or a bony deformity. Whereas if ankle is plantar flexed in knee extension, but in dorsiflexion or neutral or knee flexion, it's most likely to be due to a gastrocnemius contracture. Thank you.
Thank you, Akash. So let's again see some of the theoretical aspect of this part. So the question was about for which conditions we should use it. The important is that this test can be used for any condition, but the important question is ankle joint should be normal. If there is a problem at ankle joint, some intra-articular pathology, then the interpretation which we will be getting from this test is not correct. So the original silver skull test says that the knee is flexed to 90 degree, the hind foot is in inversion or varus, and then maximal dorsiflexion is obtained. That's the beginning position or the starting position. And as the knee is extended, if ankle moves into plantar flexion, the contracture of the gastrocnemius, that suggests the contracture of the gastrocnemius. Now, my question to both Freeman and Benjamin, usually most of us, we start with the knee extended position and then we flex the knee. Do you think that deviation from the original description does make any difference in the interpretation? Yeah, Freeman, what is your...
Yeah, I don't think so. I don't think that matters. I do think that the hind foot should be a neutral rather than maximum varus, because I think that sort of overestimates the significance. That's my opinion.
Yeah, Benjamin.
I tend to hold the foot in inversion simply because the tendency is when you've got a contracted gastrosolus, the hind foot tends to go into valgus. That's the normal compensatory mechanism. And the only way I can prevent that is to lock the subtalar joint. And that was mentioned, but I think I would only be able to lock it effectively with one hand if I inverted it completely. And so I tend to do that. And in a lot of illustrations that I have used in publications, I have shown it in full inversion. So that I do it in inversion.
Okay, so there is a slight difference in the hind foot position. Freeman keeps it in a neutral position, while the Benjamin says that he keeps it in hind foot varus or maximum invisor. But the important point is like what Akash emphasized in his lecture, that gastrosolus is not two joint, it's a three joint muscle, or it's crossing the three joints, knee, ankle, and subtalar. And the another important thing is like we have to keep hind foot either in neutral or in inversion, but don't keep it in valgus. Otherwise, we will not get the correct idea about the length. Okay, does the sequence matter? Yes, they say that the sequence is not very important. In whichever sequence we do, that's okay. Now, how much knee should be flexed? Because I saw the various pictures, and in some it is shown as a 30-degree knee flexion. Some says it's a 60 degree, some says 90 degree. So what is your response to that? In which position the knee should be? Or how much flexion of the knee should be carried out? Yeah, Benjamin, please.
I start with 90 and then I gently keep extending to see what happens. So I go
so you go with the conventional silver skull test, that you start with the 90 and then you extend.
And go all the way to extension. That's correct.
Okay, good. And Freeman, what do you suggest?
Yes, I the same. I mean, sometimes I have to admit I would start with the knee extended, but typically I would start with flexion, and I would agree. I would go to as much knee flexion as you still are gaining dorsiflexion. So that's and you know, if you go to 45 degrees and nothing has changed between 10 degrees and 45, then I'm not sure it's important to go to 90. But I think starting at 90 and watching what happens to the ankle is also very reasonable.
Good. So let's move further. So this is a chart which I have prepared for the gastrosolus assessment. With the knee extended, we measure the ankle dorsiflexion. And then if dorsiflexion is normal, that suggests that both the gastro and the soleus both are of normal length. So with the knee extended position, if both full dorsiflexion is possible, then it suggests that both muscles are of normal length, like a normal person. But if dorsiflexion is restricted, then we flex the knee to 30 degree or 45 degree or 60 degree, and then we look at the dorsiflexion. Now there are three possibilities with the knee flexion, that there is a full dorsiflexion. If there is a full dorsiflexion with the knee flexion, then it suggests that only gastrocnemius is short. If dorsiflexion improves partly, but it is not full dorsiflexion, then it suggests that both gastroc and soleus are short. And the third possibility is very, very uncommon in cerebral palsy, is dorsiflexion does not improve at all with the knee flexion. And then it suggests that only soleus is responsible for this problem. So just to put all these things in a simple to understand algorithm, with knee extension, we carry out a dorsiflexion at the ankle. If it's full dorsiflexion is possible, then both muscles are normal. If full dorsiflexion is not possible, then the next step we carry out, like we flex the knee, and then we look at if full dorsiflexion is possible, then it suggests that only gastroc is responsible. If it improves partly, means the full dorsiflexion is not possible with knee flexion, then it suggests that both are affected. And if there is no improvement, then it suggests that only soleus is responsible. I have yet to see this situation in the practice, but that's one theoretical possibility, that we get all four options or possibilities in the situation. So for assessment of the fellows, I am giving a hypothetical situation. This is not hypothetical, this is a real situation. With the knee extension, the dorsiflexion is possible up to neutral. With knee flexion to say like 40 degree or 45 degree, the 20 degree dorsiflexion is possible. So my question is, what do you conclude from this? Yeah, fellow.
Sir, both gastroc and soleus are short, sir. Because normally we should get a dorsiflexion of 20 degree. So here the dorsiflexion is up to neutral in knee extension. So
Yes.
both gastroc and soleus are short.
But with knee flexion,
Yes, sir.
a 20 degree dorsiflexion is possible. So when
Gastroc
we flex
only.
the knee, we release the gastroc, proximal end of the gastroc, and with
Yes,
that,
sir.
the full dorsiflexion is possible. So what is your inference?
Only the gastroc issue.
Yes, only gastroc is responsible, and in that case, the surgery which we carry out, we usually target at the gastroc, and the procedure which is recommended is the Stryer's procedure. Let's see another situation. So the correct answer to this is like 20 degree restrictions, which we see is by gastroc, and the soleus is normal in this situation. Coming to a case 2, the normal range of motion we consider as 30 degree plantar flexion to 20 degree dorsiflexion. That's a 50 degree arc that is considered as a normal reference. With the knee extended position, the plantar flexion is possible up to 10 degree. With knee flexion, now the dorsiflexion is possible to 10 degree. So from 10 degree of plantar flexion, we are able to gain 20 degree more, and we are able to reach to our dorsiflexion of 10 degree. So what is your inference?
Both are short.
Both are
Both
short.
are short. Very good. So both, there is a 20 degree of functional range, but 20 degrees by gastroc and 10 degrees by soleus. Again, let me tell you that this is not basically going to, I'm not trying to say that we need to quantify, but this is very important, because when we carry out a surgery, this is going to help us like how we should proceed. But ultimately, still one component is missing over here, is examination under anesthesia. We need to remember that examination under anesthesia will take out the spasticity part, and in that case, the examination finding will be slightly different in some of the cases, and we have to decide our final decision about a particular surgery after examining the child under anesthesia. So next point is about the quadriceps length. How to assess the quadriceps length? Now, let me tell you, I'm showing you a situation and I'm going to ask you a question. What is wrong? I definitely tell you from beginning that what I'm going to describe, something is wrong in this. And this test is to measure the quadriceps length. So it starts in a sitting position. The person or a child is in a sitting position. Both hips and knees are flexed to 90 degrees. Active knee extension is carried out, means we ask the patient to carry out active knee extension. Once the person is able to carry out extension, we measure the angle it makes with the horizontal line. And then we ask patient to passively extend the knee further. So this is what the picture. I want you to think and tell me what is wrong with this description.
Hip is in flexion. Hip should be in extension.
Very good. So the correct answer is that hip should not be in flexion. Why? Why?
Because the
Sir,
rectus
to
is a
start with-
biarticular muscle.
No, rectus is not the cause. What else?
To start with itself, we are starting with a short quadriceps length.
So what do you suggest? Now you said that the starting position or the sitting position or the hip flexion is not correct. Why it is not correct?
Sir, the quadriceps is arising from anterior to the hip joint, sir.
Okay.
So whenever we are sitting, the ASIs will be tilted forward, sir. So it will be shortened the quadriceps. Whenever the patient is lying down with the hip in full extension, the ASIs will be going backwards so that we can get the full length of the quadriceps.
Okay, so that's one of the argument. I accept that that's one argument, but what my understanding is, when person is in a sitting position, the hamstrings are stretched at the proximal level, and that will not allow the maximum knee flexion which is possible. So usually to assess the quadriceps length, I carried out this test in a supine position with hip extended. With extension of the hip, the proximal end of the hamstring is relaxed. Now knee is asked to flex 90 degrees. That's a starting position. We ask person or a child to carry out active knee extension, and then we measure the angle. So something like this. Here the hip is extended, the hamstrings are relaxed. We ask to carry out active knee extension. We measure this angle. We note this angle. This is the first observation. After that, we carry out passive extension. Now there are two possibilities that there is a further extension is possible, passive extension is possible. What does it suggest?
It's a lag.
It's a lag. So
Yes.
if there is more extension when the passive force is carried out, that says that there is a lag. If further extension is not possible, what does it suggest?
Fixed
Might
deformity.
suggest a contracture.
It's a
Contracture.
It's a contracture or a capsular contracture. So there are two possibilities, that either the hamstrings or a capsule which is responsible for lack of further extension. Good. So this lag basically gives us an idea that probably the quadriceps is over length, either because of the infrapatellar tendon stretching or because of the suprapatellar portion. Assessment of the patella alta, which is not very well described in the books, but that is also very important. And for that, usually I try to look at the inferior pole of the patella and whether it is its relation with the joint level. So if inferior pole of the patella is near or like say by within 1 centimeter of the joint line, I consider it as a normal level patella and the length of the patellar tendon is normal. But if it is higher, then definitely there is a patella alta, and usually in cerebral palsy, it's because of the elongation or the stretching of the patellar tendon. Okay, before we proceed, I would like to ask the third doctor, Dr. Ankleshwarya, you were supposed to say something on the the rotational or the torsional profile. Are you ready with your presentation or shall I continue?
So I was
I'm ready,
supposed
sir.
to
I'm ready,
speak
sir.
on.
Yeah, please. Yeah, Dr. Ankleshwar.
Sir, actually, I have to Dr. Arul, sir. I'm Dr. Arul from
Okay,
CMC.
yes,
I
you
have
are going to speak on the torsional profile.
torsional profile, yes, sir.
Are you ready with the presentation?
Yes, sir. Yes, sir. I'm ready, sir.
Okay, fine. So I stop at here and you will be the last point about the torsional profile. And after
Yes,
that,
sir.
we will stop the session. Thank you.
Yes, sir.
Over to you.
Sir, Dhiren sir, I have a small doubt, sir.
Yeah, please, Vikash.
Sir, the last slide, you said that examining the hamstrings with the hip flex to 90 degrees will give a false idea regarding the length of the hamstrings.
How to show
So, is it okay that we test the popliteal angle with the hip flex to 90 degrees, or will we get a more accurate idea regarding the popliteal angle if we measure it with the hip in extension?
Okay, what I will do is like I will share you the all slides. See, like the first half, that's a normal popliteal angle slides. I have hidden to save the time, but I will share all the slides with you so that will give you the complete understanding of the situation. So after that, your point will be clear. If not, you write back to me and I will try to answer that question also.
Sure, sir. Thank you.
Yeah. Yeah, Dr. Arun, please.
document.
Arun, what happened?
Sir, what is the thing?
By the time Arul is ready with this presentation, let me ask one question to Benjamin. Okay, his presentation is ready. Yeah, please.
But not time of Good evening, sir. So today I'm going to speak about the torsion profile examination of the bilateral lower limb. So it is described by Dr. Stehaley. It's a stepwise examination. It is to establish the level and the severity of the deformity in each part of the level. So all the things are recorded in the degrees. So it has 4 steps. The first is a foot progression angle, and the second one is a femoral anteversion, and the third one is a tibial version, and the fourth one is to assess the foot individually. So coming to the foot progression angle, it is an angular difference between the axis of the foot and line of the progression. So if it is an intoeing gait, it will be measured in the minus value, and if it is outtoeing gait, it is measured in the plus value. So this is the center red line is a line of progression, and the child will be walking in a straight line, that is line of progression, and we have to measure the degree between the line of progression and the foot progression. So usually it will be falling between -5 to +20 degree, and it will be constantly from -5 to 15 degree. So that is a normal foot progression angle. Anything which is deviating beyond this will be considered as pathologic. So for foot progression, that is a foot progression. So if there is a pathologic foot progression angle, there will be some problem in the hip joint, there can be problem in the knee joint, there can be problem in the ankle joint, and there can be a problem in the foot joint. In the hip joint, there will be, if there is a in-toeing gait, there can be a excessive femoral anteversion. In the knee joint, there can be internal tibial torsion that will be causing in-toeing gait. And in the foot joint, when there is a metatarsus adductus or some other deformity which is causing the hind foot varus, there can be in-toeing gait. So to localize everything, so we are doing a next step is a femoral anteversion. So Staheli has mentioned that it is a measurement of internal and external rotation which child prone and knees flexed and at the pelvis level. So normal internal rotation is 60 to 70 degrees. So whenever the internal rotation is more and the external rotation is less, then it indirectly means that there is a excessive femoral anteversion. So this is the normal hip internal rotation in case of girls and boys. For the girls, there will be a lot of internal tibial torsion, a lot of femoral anteversion when compared to the boys. So the starting for girls will be on an average the internal tibial torsion on an average the internal rotation will be from 40, but it can be varying from 25 to 65. But in case of boys, the average internal rotation will be ranging from 12 degree to 65 degree, but it gradually decreases over a period of time. So actually there is another one test for measuring the femoral anteversion, that is called the Craig test. So in which the hip will be flexed to hip will be extended and the knee will be flexed to 90 degree, and we have to rotate the leg either internal or external, and we have to put a hand over the greater trochanter until we feel the maximum. Until we feel the greater trochanter to the maximum, we have to rotate the leg either internal or external. If usually it will be anteversion, so we have to rotate the leg external, and the line subtended perpendicular to the roof, perpendicular to the couch, and to the tibia will be the torsion. So that is another method by Craig's. So Staheli has mentioned the torsion by means of internal and external rotation. Whenever there is excessive internal rotation, it means that anteversion is more, and proportionally there will be decreased external rotation. So the torsion in the thigh is sorted out. So we are either doing Craig test or internal rotation. We can find out there is a torsional profile in the femur. Coming to the thigh foot angle. So this is the angular difference between the axis of the foot and the axis of the thigh. So it will be assessed with the child prone and the knee flexed to 90 degree. We should not force the foot to be in the neutral position. So we can make the foot to the neutral position, and we should not manipulate the foot much. So we will be reading a false value. So this is the description. One line drawn along the axis of the thigh and another line drawn along the axis of the foot. So usually it will be ranging at birth. Usually it will be ranging from -30 degree to +20 degree, which will be and the average is 0 degree, and it will never fall down to, and the average will never fall down to 0 degree. By 7 to 8 years, the thigh foot angle for all the patients will be neutral or external. So this thigh foot angle can be a this thigh foot angle will tell the problem either in the transmalleolar axis or there can be a problem in the foot. So this is not very specific for where is the localizing the deformity. It will tell that there can be a problem in the transmalleolar axis, or there can be problem in the torsion, or there can be problem in the foot also. The both will tell that if there is both deformity, the thigh foot angle will be abnormal. So there is another one called transmalleolar axis, in which it is an angular differentiating between the axis of the thigh and the transmalleolar axis. This is also assessed with the child prone and knee flexed to 90 degree. So this is the transmalleolar axis. One line is drawn along the axis of the thigh and another line connecting the both malleoli. So the resulting angle will be the thigh foot transmalleolar axis. Usually it will be by 9 years, usually by 7 to 9 years, the transmalleolar axis will be somewhere around 15 to 20, 30 degrees. So whenever there is it will correctly, this will be localized particularly to tibia. Whenever there is a pathology of transmalleolar axis, so this will tell the internal or external tibial torsion. At birth, at birth to 1 year, the transmalleolar axis can be from -20 to +20 degree, and this will be progressing to the external tibial torsion. That is a normal. By 7 to 9 years, the external tibial torsion, internal tibial torsion will be progressed gradually to the external tibial torsion. That is a normal thing. So the final thing, we have to assess the foot normally. So sometimes the thigh foot angle will tell the pathology of both the tibia and the foot. So tibia we are seeing by transmalleolar axis. The foot we have to assess separately. We have to see whether there is any metatarsus adductus. When there is metatarsus adductus, the thigh foot angle will be internal. Whenever there is a flat foot, the thigh foot angle will be outwards. Whenever the equinovarus deformity, it will be once again internal. Calcanevalgus deformity, once again it will be outwards. So this is my thing, sir. I took everything from the Staheli, and I also referred some articles regarding the Staheli's criticizing about these papers.
Yeah, thank you, Arul, for a beautiful description of all the tests related to torsional profile. And if anyone has a question, please ask us, and we will try to explain. I'm very happy to say that Dr. Khatri gave me a wonderful answer about the question which I asked about why not SLR test is used and we rely on the popliteal angle test. It's a very beautiful answer, and I will start with the answer to that question in the next session. So next session is related to the non-operative treatment of the cerebral palsy children. And what I will do is, like, I have email address of most of you. So I will ask you a few questions beforehand about which you have to prepare and present in the next meeting. So once again, thank you very much, and sorry for overshooting by 5 or 6 minutes. Thank you for your active participation.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.